This is 67-year-old male, resident of Udam.
Sambhaji, I am not able to see the first slide. It is stuck in third one. I have to reshare the screen.
Oh, yes. Stop. No.
This is online.
Yes, I can see.
Dr. Pranali, you can present.
Okay, so this is a 67 years old male, resident of Udmalpet. Came with history of hematuria, 2 episodes, 7 days back, not associated with clots. History of dysuria on and off, no history of fever.
I would like to know the more details about the hematuria, particularly about the type of hematuria, whether it was total or initial or terminal hematuria, whether it was intermittent or continuous in last 7 days. How many episodes of hematuria did the patient had, and intermittently whether the patient was voiding normal urine or not.
Okay.
And
sir, he had 2 episodes of painless total hematuria 7 days back, resolved on its own. It was not associated with clots, and at present urine is clear. The hematuria was intermittent, sir. It was only 2 episodes for 2 days.
Dr. Pranali, the way to make this slide should have been painless, gross, intermittent hematuria without clot since 7 days. There will be no questions asked. In medical history, of course, the patient says hematuria, but you have to qualify whether it is painful, painless, gross, total, or initial. These are the broad things which, if you write, nobody will ask question.
Okay, sir.
And second, the dysuria. We have repeatedly told, Dr. Mohan also has mentioned, this is a term given up about 15 or 20 years back. The International Continence Society has mentioned, do not use the word dysuria. So it should be burning urination, right?
Okay, sir.
So the important thing here is whether there is pain. I assume because you are not mentioned, there is no pain. But that is the most important thing as far as the hematuria is concerned. When you say pain, what does it relate to? Let's say the history is written that there is painful hematuria. So what do you understand by that? Where is the pain? Dr. Praveen is discussing, no? Yeah.
Yes, sir. So the pain can be anywhere in the anywhere related to urinary tract, sir, starting from the flank to the bladder or the tip of the meatus.
Yeah, KUB region.
Yes,
I mean,
sir.
if a patient has headache, yes, then I will not call that as a painful hematuria. But anything in relation to the KUB region, if there is a pain, then you qualify it as painful hematuria. Okay, so is that any more history in this, or?
Sir, he has dysuria, burning micturition also. I would like to know more about other lower urinary tract symptoms, storage and voiding symptoms, if there are any.
There is no history of urge or urge incontinence, no history of increased frequency, no history of nocturia, no history of loss of appetite or loss of weight, no history of breathlessness, cough, hemoptysis, no history of bone pain, and there is no history of any previous episode of hematuria, and no history of intake of anticoagulants.
You mean to say if I have taken one anticoagulant, I will have hematuria and I can blame that for that? I can blame the hematuria because of the anticoagulant? Let's say the patient, for discussion's sake, is taking clopidogrel from last 2 years. I don't know. You mean to say antiplatelet drug or what is it? Acetron?
Antiplatelets.
Antiplatelets. Antiplatelet ecosprin. So you will pass it on saying, oh, it's because of ecosprin, just stop it and don't worry about it.
No, sir, that would be only significant when there is associated other bleeding manifestations, like bleeding gums or petechiae. If it is associated with
Not necessarily.
Yes, sir.
By and large, hematuria is not caused by any antiplatelet agent or anticoagulant unless the anticoagulant is outside therapeutic range. The presence of other areas of hemorrhage will lead us to suspect that it might be anticoagulation related. Otherwise, hematuria as a monosymptomatic occurrence with anticoagulants is not unknown. But we wouldn't take that at this juncture in the history. We'll probably use that in the discussion.
Other thing is, if the patient has some minor trauma, that would have triggered it, I agree. Second, in your management, definitely, if you are planning some intervention, you would like to stop it or change it or whatever. So you have to make a note of it, but you cannot pass it on saying that is the cause of the hematuria. That even if the patient is on acetron, you still investigate at this age to know any other obvious major causes of hematuria. Anyway, we'll go to the next.
Sir, appetite is normal, sleep normal, bowel habits are normal. Patient is a non-smoker. He used to have smoked 10 BDs per day since 40 years, but now he has stopped smoking since 1 month.
I have a couple of questions here, Praveen.
Yes, sir.
How many BDs are there in a packet?
So 20.
24, man.
25.
24, sir, if I'm not wrong. Because
25. North Indian BDs have 20. South Indian BDs have 25. And which is more dangerous? BDs or cigarettes?
One BD is more dangerous than one cigarette, sir.
In what way?
So it contains more tobacco, sir, unprocessed.
No, it has tobacco, fine, but what chemical is found more with BD smokers than with cigarette smokers?
So cadmium and nitrosamine.
Basics, Baba.
Don't know, sir.
What are the components of a cigarette?
So that cigarette is one filter will be there, sir, and tobacco will be there.
May or
And
may not be filtered.
the paper which rolls the tobacco and filter.
Okay.
Filter, sir.
Okay. No, filter may or may not. There is paper, there is tobacco. What does tobacco have in cigarettes which is different from what it has in BDs?
Don't know, sir.
Good to know. Okay, there are two components. One is nicotine and the second is tar.
Yes, sir.
Tar is a carcinogenic part. Nicotine causes dependence. You get it?
Yes, sir. Got it, sir.
Yeah. Okay.
See, as per the history, the patient has had hematuria from 1 week. Why he will stop 1 month before? Did he assume that sometime later something has happened at 1 month that would have caused him to stop it? Because he is a regular smoker from 40 years. Something would have happened. He had to go back. So because nobody will stop just as it is. Anyway, either the history should be 1 month or something wrong there.
Does the patient has any other comorbidities or
No, sir.
any family history of any malignancies?
No past history, no family history.
Okay. So he does not have any comorbidities also, sir. At this his level of history, I would like to have a differential diagnosis of carcinoma bladder, sir. And second one will be benign prostatic obstruction, RCC, and the next one will be the upper tract TCC, sir.
Can you think of common causes also? Absolutely correct. The diagnosis is urothelial carcinoma of the bladder unless proved otherwise. But anything else? Because you are stuck with mainly malignancies and one non-malignant BPH. Can it be anything else?
It can be stone disease also, sir. It can be renal stone or bladder stone also, sir.
Then your exam going, man, you should rattle off. See, you have to classify your this thing answer.
Yes, sir.
I assume Manish will always say that you classify your answers, and then you are unlikely to miss. Otherwise, you are going to just pick up here and there, very picking. Yeah, so classify. Then more likely you will tell the complete list of causes.
The congenital causes, the PUJ obstruction and diverticular disease are unlikely to manifest after 67 years of age. That too recently he has developed hematuria. And acquired diseases, apart from what I have elaborated, inflammatory diseases and infective diseases are unlikely, provided there are no other constitutive symptoms, or fever, malaise, loss of weight, and other constitutional symptoms are not there. So tuberculosis and other infective etiologies are unlikely. So,
urinary tract infection.
Yes, sir.
Can produce hematuria. He also has burning micturition. Before you put the patient suspect as malignancy, he may be more reassured if you say it may be just a UTI. Anyway.
Yes, sir.
Okay. Right. So what do you want to examine in this patient? Of course, vitals are all right.
So, there is no pallor, and vitals are stable. Only 2 episodes of hematuria was there. And
is there anything missing in the personal history, Praveen, that you would be interested in? All this is okay. Before we go to examination, is
Yes,
there
sir.
a bit of history missing that would interest you?
Sir, history of this bowel habits, sir.
Why would that be connected to hematuria? See, he's not presenting to you with urinary tract symptoms.
Yes, sir.
It's not hematuria. With respect to a symptom of hematuria, what other history could be significant? What work does he do?
Occupational history.
Madam, what is his work? Or what
Yes.
was his work, ma'am?
He is a farmer, sir.
A farmer. When would you be worried?
Sir, if the patient is some industrial worker with exposure to carcinogens, as cadmium,
Can't you simply put it
aniline dye?
as somebody exposed to chemicals,
Yes, sir.
organic chemicals? He might be an industrial worker, he might be a printing press worker, he might be a textile worker, whatever.
Yes, sir.
Okay. So, see, make your answer short. This is something I have to tell all residents. Don't answer like you're expert sitting on a panel on the stage in the USA conference. Make
Yes.
it to the point so that the examiner has a chance to run through the entire gamut of the case to know how you think. When you start adding adjectives, you're unnecessarily wasting time and you might be irritating everybody.
Okay, sir. So general physical examination, there is no pallor and ECOG score is 0. Vitals are stable. Next slide, please.
Go back. What do you mean vitals are stable in one reading, man?
Only 2 episodes we had, sir.
Sorry, you measured only once. So you can't say vitals are stable. Stability is over a period of time. Correct?
Yes, sir.
Then this is one reading. Is there anything here of interest?
No, sir.
Pulse rate of 80 is all right?
Yes, sir.
Really?
Yes, sir.
Why so?
So it is in the normal range, sir.
It is in normal range.
Yes, sir.
What is the normal range?
The normal range is 60 to 100, sir. Per minute.
Really? At what age, Praveen?
Adult patients. Sir.
No, it's all right. If you don't know, say you don't know. Don't bluster your way through. Okay? If somebody came with a heart rate of 90 or 100, you would be worried. You wouldn't call that normal.
Yes, sir.
Does anybody else have anything to contribute to normal pulse rate in an adult?
22, sir.
Range. Well, please look up. Okay, and probably 100 is not okay. Yeah, carry on, please.
So for abdominal examination, patient was soft and non-tender, no palpable hepatosplenomegaly, no mass palpable, no scar, sinuses, dilated veins seen, hernial orifices were clear, external genitals were normal, per rectal examination was normal.
Sir, since my one of the differential diagnosis was carcinoma bladder, I would like to have findings of bimanual examination also, sir.
Have you attempted bimanual examination in an awake patient?
Yes, sir. It is a bit uncomfortable, but...
Praveen, what is the intent when we do bimanual?
Sir, if there is any palpable bladder mass...
What are the requirements for that?
The patient should be relaxed.
This is how you're going to put your foot in the mouth in the exam. For a bimanual examination, you want the bladder to be empty and you want the muscles of the abdominal wall to be fully relaxed.
Yes, sir.
Can you achieve that in an adult patient?
Sir, ideally it should be done under the general...
Don't argue.
Yes, sir.
Just understand what is being said. You don't come to bimanual examination here. Okay. If you have a mass palpable on rectal examination, then the rest of it kicks in. If there is nothing palpable on digital examination, what are you going to palpate for on bimanual?
Okay, sir.
Not okay. You think anatomy. I don't know if Dr. Prabhu has a different opinion or if Dr. Ganesh or anybody else has got a different opinion on this. I don't know if Dr. Karthikeyan has got a different opinion.
In this examination, if you written PR normal, I would still comment. You should, at 67, you should mention about the prostate details. Bimanual examination is not done under local because the patient, sometimes obese, you can't feel properly the prostate also. You can only feel the tip of the apex of the prostate. So thinking about examining the entire thing with the finger above and below is too much. I don't think anybody will expect you to say bimanual examination in a hematuria case. It is under anesthesia. That is specifically for that. If during cystoscopy you have not mentioned it, there are some people who will criticize you or penalize you for not mentioning that, but not during the clinical examination.
Okay, sir.
Of course, the prostate is not mentioned. You can't just write as a urologist, if you are doing a rectal examination, if you write normal, I would be a little bit, because you need to mention about the prostate at least. Prostate is about normal size, flat, or mildly enlarged, benign, non-tender. That is definitely a minimum thing that has to be mentioned. Anyway, how do you proceed now?
Sir, I would like to have a brief rest of the systems examination, sir, just to make sure that is normal. And investigations wise, I would like to get complete blood picture and urine analysis, urine culture, and renal function tests as a preliminary investigation.
You said complete blood picture and then renal function test. Means I don't know what is complete blood picture.
The complete blood picture includes hemogram, sir, complete hemogram.
Be specific. I mean, you can classify that as basic test and specific test, one, or you rattle off what all you want. I mean, you cannot say complete blood picture means I don't know whether you're going to ask everything like tumor markers. Is that specific? Whatever. Yeah, okay.
I would also like to get urine cytology at this point.
Other system.
Okay, yeah. Dr. Pranal, you can, yeah, anyway, I think it's all normal.
Yeah.
The other problem is, see, this patient has a chronic smoker, a physician or somebody may find out there is abnormality in the chest with the crepes and other things, and you simply, patient is a gross COPD patient and you say everything is normal, again problem. If there is abnormality, you may not be able to pinpoint and say that. And you are, of course, the physician will definitely not accept the surgeon writing normal. But anyway, for completion's sake, fine. What is that? NFND?
No, so it's a by mistake. I have written that NAD, no abnormality detected. I had to write.
No focal urological deficit, he has written.
Yeah. Yeah, in both the slides, the examination spelling is on the top.
Yes.
I think it is the missed one I and E are missing. Anyway.
Creatinine.
So you would have asked PSA, Dr. Praveen?
Yes, sir. This is patient is 67-year-old patient, sir, and he happens to be presenting to the urology clinic for early detection. And we also have one of the differential diagnosis down the line as a CA prostate. So I would like to have PSA.
Would you have done a PSA based on your rectal examination, and and how common is CA prostate presenting with hematuria?
It is less, even if the DRE is only around 15 to 20% sensitive for CA prostate detection alone, sir. So with considering age for early detection, I would still recommend to get serum PSA, sir. And CA prostate presenting with hematuria is less likely presentation, sir.
So I would put the PSA came as 8.
So that then it needs further evaluation, sir, in the form of the serum free PSA and free to total ratio. And if it is more less than 25%, I would like to have a prostate biopsy also, sir.
Yeah, see, when I asked you the question, would you have done PSA? That was a time that I was trying to tell you that you will withdraw your statement. The saying is, you are digging more and more. In exam, you should know if some question is asked like this, you should know. I would have not asked for it. You should understand what the examiner is intending to drive the message. Why would you do a PSA when the cause of hematuria is unlikely, very uncommon to have a patient presenting with hematuria due to CA prostate, and your rectal examination being normal? Third, when there is an acute event, the PSA can actually go high, and you may be in a false high elevation. You will be simply putting so many other doubts and differentials in both you and in the patient's mind. What is more common? You look into that. You come back at a later date if you want. There's no problem.
Yes, sir.
So in some places, as part of your statement, do all complete blood pictures. Everything is done. Even for females, they'll do PSA. But you should know, you do it when what is specific to the patient. I would, not very be happy if you say that I will do a PSA in the normal rectal examination. I may be wrong, but you should be able to defend yourself if you say, I wouldn't have asked for it. Nobody is going to penalize you for not doing a PSA. In the initial part, you may change it little later date. Suppose you find some bladder tumor, why you still want a PSA on that? You want, okay. We have seen the urine? No. It's
Anybody else from Vedanayagam other than the presenter, Dr. Pranali? Anybody else? Or Hardik? Anybody from Puttaparthi who is logged in? Kalyani, anybody?
Hello, first.
Who's this?
Hardik, sir.
Yeah, Hardik, there's a question for you. Somebody has presented PSA is 2.01. Okay.
Yes.
So the examiner is asking you this question. Why was the PSA done? Why do you think the PSA would have been done? Or if you have done it, why would you do a PSA? One way is saying, no, I won't do it. But the examiner isn't happy, or by the examiner, even you aren't happy.
If sir, a patient presented with lower urinary tract symptoms and his age is 50 to 60 years.
Okay, I get your point. Anybody else wants to answer this?
We can explain the patient about consequences.
Anybody else wants to answer this? Would one do a PSA? Is it necessary? Is it important? Saurav is not online today.
Is there, sir? Yeah.
Shubham. Shubham is not online.
Sir, Sambhaji, sir. Sir,
No, Sambhaji, I want somebody from the other institutions because they usually keep quiet. Okay. See, if you are presented with PSA and asked why did they do a PSA or why did you do a PSA, one way of answering it is saying, at this age, it is our practice to screen for CA prostate also. Then the question will be, is it relevant to this presentation? To which your answer can be, no, in this presentation, I would be thinking of other things. But in a patient, according to the current recommendations, if there is a screening program underway either in the country or in your institution, you would be justified in doing a serum PSA, provided you say this is part of our screening protocol. Don't put it as necessary in a patient who has hematuria. Okay, let's carry on.
Another word, sir, Praveen, whenever you do a PSA, you should discuss with the patient these points. It is not something like you ask hemoglobin TCDC. The
Yes,
PSA, if you are asking, it should be, there is a word like discussion. Like you do HIV test, you should explain if it comes positive, what you do, if it's negative, and there is a gray zone. All this part has to be discussed. Definitely in exam, they will like you to mention this, that I will discuss the pros and cons of doing a PSA, and then you should go ahead with the doing the PSA. So it is not just a simple blood test, but a word of caution should always be mentioned because the patient can end up with a lot of anxiety. Now, that is what you are not thinking from the patient point of view. It puts the patient in a lot of anxiety if the PSA comes between 4 to 10 and he will read the Google and everything. So that is one of the criticisms for doing PSA. Anyway, proceed.
Yes, sir.
Yes.
My question is, what is opportunistic screening? Opportunistic screening?
Dr. Praveen, did you get the question?
No, sir.
You could
What
hear
is screening and what is opportunistic screening? Is there any difference?
Sir, opportunity screening and one more, sir.
Yeah, regular screening program. Because Mohan sir was telling about screening, isn't it?
Yes, sir. So general
What is
screening.
the difference between screening and opportunistic screening?
Screening is for the general population, sir, and opportunistic screening is the screening which is done when the patient presents with some other symptoms not related to the particular disease which we are screening for, and we will take that opportunity.
Yeah, stop there. Praveen, please stop there. No gas here, please. Opportunistic screening is screening for a patient with lower tract symptoms who's come to your clinic, and you decide, you counsel him and tell him, I will do your PSA. Is that correct, Karthikeyan?
Yes, that's one thing.
Okay.
Next is informed consent for PSA. That's a big topic by itself.
Yeah.
How do you counsel the patient for PSA?
So counseling.
Isn't it?
Yes, sir.
This patient had PSA of 2. Before doing the test, if this patient has come to your clinic and you want to do an opportunistic screening, how do
If you don't mind, can I intervene here? I think the case is about other things. We'll take up this issue when there is a prostate case to be discussed. Can we proceed? Karthikeyan,
Okay,
I hope you don't mind.
Sure. Yeah, no problem, sir. Go ahead.
Yeah, let's proceed with the case.
Pranali, some spelling mistakes like urobilinogen, please look into it,
Yes,
right? All the eyes look into every details. Praveen, you can interpret the report.
Yes, sir. Urine routine examination and microscopy showing turbid.
Your interpretation. I'm not saying showing, everybody is seeing. Your interpretation, please.
So it has microscopic hematuria and proteinuria, sir.
What the eyes doesn't know, whatever. There is RBC cast there. What does it tell you?
So casts likely coming from the kidneys, source of bleeding from the kidney. Tubules, renal tubules, proximal to the renal tubules.
What does it made up of? How it is made up of? What protein it is coated with? Some name you remember?
Tom Horsfall protein.
So if the pathologist or the biochemistry person has mentioned cast, you should look at it. It is not in a patient with a lower tract tumor, getting a RBC cast is not common. So straight away it may be indicating that this is from the upper tract. Anyway, just for this thing. Anyway.
Patient had come with the cytology report from outside, sir. It was negative for malignancy and dysplasia.
Will you do is a culture done or not?
Culture done, sir.
Culture is missing, I think. Anyway, we take it as negative.
It was done, sir. No growth was there.
Okay.
It's a
hemoglobin and all, I think we saw.
Hemoglobin is 10.2, I forgot.
Okay, we'll assume that it is normal. Fine. Next, ultrasound. Praveen, quickly.
So, in the first image in the left upper corner, showing the image of the ultrasound of the bladder, sir. It is showing moderately distended bladder with isoechoic mass, which seems to be sessile in the posterior lateral wall of the posterior wall of the bladder with post-acoustic enhancement, sir. The mass is smooth surface, and the rest of the bladder seems to be normal, sir.
with one image, how can you say rest of the bladder is normal? It is in the posterior wall, right side, left side. You cannot tell me.
Side I did not tell, sir. Only in the posterior lateral.
How can you say rest of the bladder is normal with one image provided?
The rest of the image is normal, sir.
You used a term called isoechoic.
Yes, sir.
Isoechoic to what?
To the bladder wall, sir.
You have to really imagine that. I would call it an hyperechoic space.
In fact, the bladder wall itself is hyperechoic, a normal bladder wall. Praveen, remember, and everybody else, the term isoechoic is usually applied to the renal parenchyma in relation to the liver, because we have a neighboring organ with which we can compare the echogenicity. Okay, when it comes to masses in the bladder, the correct description would be whether it is heteroechoic or uniformly echogenic, whether it has a posterior acoustic shadowing, and characteristics like whether it is pedunculated, whether it is sessile, and whether it is free floating. In addition, one would expect you to comment on the adjacent bladder wall if that is possible. If the entire bladder screening images are available, multiple images, you would say then whether the rest of the bladder appears normal or not normal. Here the image has been labeled. They have labeled the UVJ. It is not usual to label the UVJ unless the ureter is dilated up to the uretrovesical junction. That should be a clue you must pick up.
Yes, sir.
Continue.
And the right side image showing kidneys, I don't know whether they have labeled which side kidney. I am not able to make it.
I can make out means the left kidney there, which is showing some abnormal.
This is normal, sir, and this is showing hydronephrosis. Ureter, I am not able to make out, sir. And the kidney, there is loss of corticomedullary differentiation, and parenchyma appears to be mildly thinned out, sir. And this is the image of the liver.
Not every hydronephrosis is associated with thinning of parenchyma. You compare the parenchymal thickness to the opposite side and see whether it is significantly reduced. When you say parenchymal thickness is reduced, it carries a different connotation. Hydronephrosis can be present even in acute situations. Parenchymal thinning is usually a consequence of long-standing obstruction.
Yes,
be
sir.
careful in your choice of words. Compare again. And you want to compare parenchymal thickening at which point in the kidney, where in the kidney? It's usually at the poles.
Yes, sir.
Correct.
Yes,
So
sir.
be a little careful. Don't be exuberant with words. It'll get you into trouble.
Yes, sir.
Praveen, I'd also like you to note something that Dr. Mohan had just said. Look at the echogenicity of the right kidney and look at the echogenicity of the liver. What do you think it looks like?
Sir, kidney, the cortex is hypoechoic, sir.
Yeah, as compared to the liver. So that is what a normal kidney should look like.
Yes, sir.
Okay.
Yes, sir.
Okay, so now what do you want? Or what is your interpretation up to now?
So this is up till now. There is one bladder tumor is there, sir, and cytology is negative.
Hey, don't go into all that. On this set of images, what is your impression? Praveen, you must learn to save time, Praveen. Don't go on and on.
This is a case of probably carcinoma bladder with left hydroureteronephrosis, sir.
Correct.
Yes, so why hydroureteronephrosis? Does it give you any information about the bladder tumor?
And what is the bladder tumor commonly called as otherwise? I told long back also, urothelial carcinoma unless proved otherwise. So why are you saying carcinoma bladder? You are thinking of something else?
No, Prabhu will still grant him that at this point, but he's missing out on other things. If there is hydroureteronephrosis, what else will you look for?
So if there is any defect, any tumors in the upper tract are the VUJ.
In the images given,
Yes, sir.
with Dr. Manish has already pointed this out to you.
Yes, sir.
What about the tumor that you're seeing on ultrasound interests you when there is hydroureteral nephrosis?
The location of the tumor, sir, whether it is close to the...
Again, like he says, no gas. Location, what else are you interested in?
And ureteronephrosis, sir, if it is
It
associated.
is there in the presence of hydroureteral nephrosis
Yes,
on one side. What about the tumor, in addition to whether it is close to the ureteric orifices, would you be interested in, which you will either rule in or rule out?
In a case of bladder tumor, if there is hydroureteral, so what does it indicate to you?
Sir, it is likely to be muscle invasive, but in ultrasound we will not be.
How will you make out an ultrasound whether it's muscle invasive, deeply invasive? You must know what you can pick up on ultrasound, what you cannot pick up on ultrasound. Right?
Yes, sir.
What is the evidence that a tumor is muscle invasive on ultrasound?
So posteriorly, if the
only if there is bladder wall thickening, otherwise you can't make out. On the other hand, what is it you can make out about invasion on ultrasound? Is the perivesical fat hyperechoic or isoechoic compared to a tumor?
Yes, sir. This is
Is
hyperechoic.
the perivesical fat characteristically in ultrasound hyperechoic or isoechoic to a urothelial tumor in the bladder?
It is hyperechoic in this case.
So if there is breach in the hyperechoic layer around the bladder in relation to the tumor, you know the fat is invaded. Otherwise, we cannot say. But are there other indications in the morphology of a bladder tumor which will tell you it is invasive, which is bringing us back to the question Dr. Manish asked you?
Sure. Sessile lesions are more likely to be invasive.
Manish, your case, Manish.
So on the ultrasound, the bladder tumor lesion per se, you will not be able to make out too many details. But if there is ureteronephrosis, there is a 90% likelihood that you're dealing with a invasive tumor. And
Manish, one more point that we need to emphasize here is that the symmetry of the bladder. Most of the times these ultrasounds are done when the bladder is full, but if there is some degree of invasion on a particular side, then the bladder on that side in a full bladder picture can't be symmetric. So that may be one of the pointers that these guys can actually emphasize on apart from the failure cycle.
So, Dr. Praveen, what are the causes of hydroureteronephrosis in the cases of bladder tumor?
One, it can directly involve the bladder tumor. Directly involves the vesicoureteric junction, sir, infiltrating, and second one can be concurrent upper tract tumor causing obstruction and hydroureteronephrosis. And
no, there is no upper tract tumor. There is only a bladder tumor, hydroureteronephrosis. What could be the causes of the hydroureteronephrosis?
Sir, enlarged lymph nodes causing ureteric obstruction can also present with
what is more common?
Bladder tumor involving VUJ is most common, sir.
We've discussed, you said that. You said a tumor that involves the ureterovesical junction. What else? You said lymph nodes. What else?
That's all.
Can there be any other tissue involved whose involvement causes compression of the ureter? If nodes are involved, before the nodes, is there anything else? Are there any other tissues?
Perivesical fat.
Lymphatics, man.
Yes, sir.
You see, in the trigone area, the lymphatics are packed. And the trigone itself is rigid. Therefore, lymphatic obstruction is another cause of hydroureteronephrosis. And this can happen even if the tumor is not in relation to the ureteric orifice.
Okay, sir.
And the last in the list will be another tumor somewhere in the upper tract, ureter or in the pelvis. Okay.
Yes, sir.
Yeah, let's move on.
Looking at the ultrasound, you would have asked for a cytology. Let's say the patient came with the USG report and now.
No, sir.
You won't have. Okay. Proceed.
I want to have the dimension of that tumor.
Will you be debating on the ultrasound or you will do something?
I will do CECT KUB, sir.
Why CECT KUB only, man? Is there a specific machine?
I knew this was coming.
No, is there a specific machine which does only that, or is it a reduced rate, or what? They blank out all the other things and only give you the kidney, ureter, and bladder.
No, so CECT, abdomen, and pelvis would be the ideal image.
Why do you want to get yourself into the mess?
Yes, sir. So it is the CT plane images showing the cross-sectional images with the left hydroureteronephrosis. Next section, please.
Wait. We just said this is not CTKUB. Any other organ you would like to talk about?
Liver is normal, sir. And the contralateral kidney is normal. And there is no apparent retroperitoneal mass suggestive of lymphadenopathy.
You're suggesting then that there could be any inapparent mass? Don't use these adjectives, man.
Yes,
Normal liver, no lymphadenopathy, whatever else you want to put it. No apparent, no visible. What's the point?
Yes.
Next.
So in the sections above, there is bladder mass is being seen, sir, not clearly delineated in the bladder part.
Quite clearly delineated, but if you can't see it, it's all right. Let's move ahead.
Which phase are you interested in now?
So I'm interested in cardicomedullary phase now.
In a bladder tumor?
And delayed phase, sir.
What did you want to see on the corticomedullary phase?
The function of the kidney, sir. Whether it is contrast uptake is good compared to the opposite kidney.
Anyway, just for exam going PGs, now we were earlier talking of nephrographic and other things. Now, most of the CT, if you read and talk to radiologists, they classify as arterial phase, venous or the portal phase. Yeah, no. Arterial phase, they say portal phase and delayed phase. I know at the time when we were doing IVUs, this point of corticomedullary, excretory, these terms were used. Now they all talk about arterial, venous, and delayed or excretory phase.
The textbook still talks about the corticomedullary phase, and specifically if you want to make out a small renal tumor, that is where you would look at the corticomedullary phase. Can you give him the delayed images?
So this is the reconstructed images show that there is left hydroureteronephrosis with tumor occupying the superolateral wall of the bladder on the left side, sir.
What is this reconstruction on your right known as?
The maximum intensity projection, sir.
Okay. Are you happy at looking at this, or would you have wanted something else?
I wanted the volumetric projection also, sir.
You will want only the axial cuts, and you will assess it based on those axial cuts in your head. Whatever reconstruction they do can carry fallacies. Remember that.
Yes, sir.
Okay, so now how do we proceed? Oh, okay. Yeah, your clear bladder tumor is there. You please describe these films.
Sir, in the films where there is no contrast in the bladder, there is radiodense mass in the posterior wall of the bladder, which is sessile, and in the delayed phase, there is a filling defect in the same area of the bladder mass with multiple projections, probably papillary projections from the tumor.
Anything more important?
Praveen, you look at the second film in the top row, right? What do you find there in the second film? Look at what you can see of the bladder. You can also look at the third film, which has contrast. Correlate, and can you tell us what it shows? There is a specific pathological term which immediately comes to your mind when you look at these two.
Sir, it is likely to be...
No, I'm not asking you what it's likely to be. I'm asking you what you see.
The peripheral fat planes are not clear, sir.
Look at the mass, Praveen. I'm not talking the perivesical fat.
The broad-based mass, sir.
It is an infiltrative mass. You can see there is a main portion to the mass, and then there is thickening on either side, which you can also see in the film, which in the third film, where you can see the contrast separating the mass from the rest of the bladder, right? Yeah. The area where contrast is not taken and the bladder wall is thickened is extending on either side of the main mass. So this is indicative of an infiltrating mass. So you'll make everybody very happy if you say there is an infiltrating space occupying region in the bladder, which shows enhancement or which is hyperdense on the plain film. And then you go on to mention whatever is happening. The next thing when it comes to bladder tumor, infiltrating mass, ureteric orifice, ureter, if you can see, you cannot see. And then the adjacent structures. Don't run away to the kidney. What about the adjacent structures? We have the seminal vesicles, we have the prostate, we have the perivesical fat, and we have the rectum.
These are the seminal vesicles, sir. And here the fat planes appear to be not very clear, but in the rest of the films, the fat planes are well preserved, sir. And this is the rectum.
Hardik, I'll ask you this question to give Praveen some rest. What is important, that it is not seen in one place or that it is seen normally in the rest of the places? The fat plane.
Not seen in sir. No.
Sorry?
Not seen sir normally in fact.
Normally not seen, normally seen. No, I'm asking Hardik. Please wait, Praveen. We're giving you rest.
Sir, in a middle, in the third images, it will be...
No. I'm asking you, in a series of CT scan films or a CT scan exposures, you're seeing the fat plane in 90% of the cuts. maybe 99%. In one cut, the fat plane is missing. So is the 99% important or the 1% important?
Sir, 1% important because not seen.
Yeah, please remember, absence of fat plane, even if it is only in the limited number of sections, is significant. Not that the fat planes are normal in the rest. Fine?
Yes.
What other aspects, Praveen, in this set of films would you be interested in? We said the tumor, we said the infiltration, we said the adjacent organs, we said the fat plane. What else would you be interested in?
Sir, lymphadenopathy, sir.
What else?
And other concurrent tumors, anything visible in the CT?
What else? You are always on other tumors. Complete what you're seeing first before you go to other tumors. Would you want to know whether the lateral pelvic walls are free or not free?
Yes, sir. The tumor and its extent, sir.
Yeah. It takes special talent to beat Praveen and get him to back into focus. Okay, so you have a tumor, you have the adjacent bladder, you have the fat planes, you have the adjacent organs, you have the lymph nodes, and you have the lateral pelvic wall. One has to finish all this before going away from the bladder tumor while describing the findings on radiology. Okay?
Mohan, can I just point out to Praveen? Praveen, if you look at these images, don't look at the top right image.
Yes, sir.
When you look at the screen, don't look at that. Look at only the axial cuts, which shows the bladder, and see that mass without the contrast in the bladder and with the contrast in the bladder. Compare the right side, that is the patient's left and the patient's right, in the base of the bladder, just above the seminal vesicles, and then you will see exactly what the difference is, and you'll be able to point that out very clearly. All right? And this will give you more, brownie points to make a diagnosis of possible muscle invasiveness. All right?
Yes.
More pointed out in that, if you put the mouse on the second film where the tumor is, and then you see that there is urine inside that bladder, and then there's an area which is enhancing the base of the bladder. The mass itself is protruding, and then the base of the bladder appears to be flatter. So there's a flat area and there's a mound area. Now that flat area appears to have flattened out when the contrast is there. But then if you look at the extreme end of that mass, lower end, and you see compared to the one side and the other side, and then go down to the next film, and then you see exactly what is happening at the base of that tumor. Then you put all these things together and say, because of this, I note that there is a difference. See, we have to compare the left with the right. This is a situation where what is there predominantly on one side. That's why we've got, for comparison, right kidney, left half of the bladder, right half of the bladder, all that. And the symmetry of one side versus the other, you can very clearly see that there is a problem at the bladder base. You can also see that there may be a separation between that infiltration and the seminal vesicle, which is noted in the last film. Last film that's not, yes, axial cut, the one that's extreme right, yes. There's a little bit of a plane between that mass effect and the seminal vesicle, which may suggest that the seminal vesicle may not be infiltrated yet. So, an MRI may be a better way, or if the resection the CT has been done before the resection is acceptable, but if it's done after resection, then you can get artifacts. It would appear that this is done before resection. I'm just taking a guess, I don't know. So the CT was probably done before a TURBT. Before TUR, okay. So that's why the planes are quite clear. If you do this after TURBT, then sometimes you can get a different picture, a little exaggerated picture, but you're not doing that for something, you're doing that for something else. So just make sure that you look at the images very clearly and don't jump. Read the x-rays. We keep telling you guys, read the x-rays. Don't make a diagnosis. Diagnosis staring in the face. But why are you making that diagnosis of urothelial cancer is what is important. Which grade it is, which likely grade, which likely stage it is likely to be. So, okay. Carry on. Sorry.
Okay, sir.
So Praveen, this is the CT finally. So what do you want to do now?
Sir, I would like to have a chest X-ray also, sir, now. And I would like to proceed with cystoscopy and TORBT, sir.
Let's assume that the chest X-ray shows metastasis.
Yes, sir.
You ask for the chest X-ray, it shows metastasis.
So then I would like to do TORBT.
So you do a TORBT irrespective of the chest X-ray.
Yes, sir.
So why do you mention the chest X-ray at all?
So that needs for complete workup of the patient. Sir.
You are asked, what will you do next? Your focus now should be on diagnosis of the lesions that are visible.
Yes, sir.
Let the examiner ask you, want you to do a chest X-ray? You say, yes, sir, I will do.
Yes, sir.
So your next step is going to be a cystourethropy followed by whatever you're going to describe now. Okay.
This is where you are right now. You've done the cystoscopy, 4 into 3.8 centimeter lesion. Now what do I do?
So I will do a TORBT, sir.
Think again. I have done the cystoscopy. This is what I'm looking at. What do I do next?
You put the hand in the mouth, something we told, no?
He first put his hand in his foot in his mouth. Now he has to put his hand somewhere. Let us see where he'll put it.
Bimanual examination, sir.
Yeah. Okay, at cystoscopy, Praveen, what are the prerequisites before you do a bimanual examination?
So bladder should be completely emptied and patient should be under general anesthesia with complete muscle relaxation. And
don't say general anesthesia. Patient must be relaxed. Because they may give a spinal. You can get very good relaxation in spinal also.
Yes, sir.
You just say, I would like a relaxed patient. That's all, completely relaxed.
And one finger in the rectum and one hand on the lower abdomen, sir, suprapubic area. I will try to palpate the mass, sir.
What else will you do with the finger in the rectum? And this mass?
I'll try to push it anteriorly.
Palpating it. What are the other features that you would like to look for?
Mobility, sir. Whether it is mobile.
All right. Anything else? Of course, you've got the CT. So, nowadays, people don't even do anything. They don't examine the patient at all. So, it's a different call.
And extent, whether it is extending into, if it is fixed, whether it is fixed to the lateral.
Fixity to the pelvic side walls. All right?
Yes, sir.
Yeah. This is, make that a routine so that when you have the index case where it is likely to have that happen, then you know that you've covered all the angles. So, yeah, fixity is very important.
Yes, sir.
Biopsy TURBT specimen showed low-grade urothelial carcinoma, laminopropria invasion absent, lymphovascular space invasion absent. Deep biopsy does not show any muscle invasion by tumor. Left ureteric orifice specimen also reveals non-invasive low-grade urothelial carcinoma.
Yes, Praveen?
Surprised, huh?
Yes, sir.
Huh? So, if you're surprised, then what will you do?
Sir, next, so this is low-grade non-muscle invasive bladder tumor, sir. Not even invasion into the lamina propria.
Can you put it in TNM terms, please?
The TA tumor, sir. It is TA N0M0, sir.
See, they've reported that the left ureteric orifice tumor also reveals something. As the endoscopist, what is important for you here?
Sir, I would like to differentiate whether the tumor was arising from the ureteric orifice or it was the bladder tumor which was extending into the ureteric orifice.
Yeah, whether it was contiguous or whether it was a different area.
Yes, sir.
Praveen, could this have been some other way by which this tumor presented, considering now that you have seen the CT, you made a diagnosis and you thought that, oh, you got the biopsy now?
Yes, sir.
Would you like to consider any other diagnosis? We know that this is urothelial cancer, but its origin.
Yes, sir. Maybe cystitic cystica glandularis.
No. Could this have been primarily a ureteric tumor which is coming out and sitting in the bladder, not involving anything at all?
Yes, sir.
Because the bladder is clean. There's no muscle invasion there. There's nothing there.
Yes, sir.
Appropriate invasion is absent. Lymphovascular invasion is absent. That's the bladder.
Yes, sir. More likely that ureteric tumor.
Tumor sitting in the ureter. So was this a tumor which rose from the lower end of the left ureter near the orifice, projecting out, and that's what you see?
Yes, sir.
So given the CT findings and this biopsy report, what will you do now, Praveen?
Sir, since it is involving the bladder and as well as left ureteric orifice also, if I would like to do.
It doesn't seem to involve the bladder.
Sir?
It doesn't seem to involve the bladder. Lamina propria invasion is also absent. Lymphovascular space is also absent. It just so happens to be within the bladder that it is shown as TURBT.
Yes, sir. Sir, it is a low-grade tumor arising from the left distal ureter, sir.
That we are hoping that could be one of the diagnoses. But what will you do now at this point?
So to confirm that, I would like to do ureteroscopy, sir. And if there is a lesion, I would like to take a biopsy from that also.
When you do ureteroscopy, what else will you do?
RGP, sir.
When will you do all this?
After the biopsy report came now, sir, so I would like to do after 4 weeks, sir.
You will just do RGP and ureteroscopy. Will you do anything else?
Is it an indication for like a re-TURBT in this case?
No, sir, it is a single tumor. So, yes, sir, it is an indication for re-TURBT, sir. Size of the tumor is more than 3 centimeters.
So, more than the size of the tumor, your clinical impression, the CT findings, and this lab report of the pathology, as a clinician and as a urologist, you have to have a high index of suspicion because the window of opportunity could be very small in this patient. So here, what you would like to do is to go ahead and again, de-resect that area and then look at that ureter.
Yes, sir.
Supposing you find that the left ureteric orifice, you can't identify it, it's narrowed or stenosed, what do you do? Said I put ureteroscope. Now I can't find that hole to put ureteroscope. What do you do?
Then if there is hydronephrosis, sir, so we have to put a PCI.
It was there before.
Yes, sir. I would like to have an antigrade access and then instill methylene blue and see where the ureteric orifice is exactly, sir.
You put methylene blue and then you'll try to resect that orifice. Suppose you don't have access, what do you do?
Then, sir, we have to do antegrade ureteroscopy, sir.
Antegrade ureteroscopy. Can you do something before that? You can resect the area of the orifice again. You know where the orifice was, isn't it?
Yes, sir.
You know from the previous CT scan that the ureter was involved right up to the bladder. It is
Yes.
not somewhere halfway. So you're not worried that you're going to go and cut into the, into the iliac area and all that. So this obviously is something that is happening at the level of the ureteric orifice and in the submucosal and the muscular layer of the bladder. So you can resect this area and try to uncover that orifice. It will be sitting there only.
Yes, sir.
Try to uncover this orifice and you may find the orifice will open up. If that doesn't happen, and you're now getting into territory which is tiger country, then you will have to go in and see if you can do something else by putting a flexible scope up from above and come down and all the rest of it. But in the vast majority of patients, you would be able to resect that orifice and open it up and see whether there is any tumor inside. Okay?
Okay, sir.
That's the first thing you do because anyway you have a resectoscope with you.
Yes, sir.
Yeah. And you're anyway going to do a re-TURBT in that area.
Yes, sir.
Now, what is most important about this re-TURBT?
So re-TURBT during inspection, sir, that if any recurrent tumor are
little dirty, inflamed, some red areas and all that. It doesn't look neat at all. It's all very ugly.
Yes, sir. That resection of the previously resected area.
As a urologist and as somebody who's an oncologist, how will you proceed with this re-TURBT in terms of basically making sure that you get the diagnosis? Because it's important, no? Your
Yes,
index of suspicion is that this is muscle invasive. These
Yes.
fellows have said this is not invasive. So the ball is in your court. Don't chuck the ball in the pathologist's court.
Yes, sir. I will
reported what you have given him.
I will resect the previously resected area till the fat is seen, sir.
No, the answer is that you will resect separately and label each specimen separately because only you know where you've taken it from.
Yes, sir.
This is something that we don't do at all in our country. Many people just resect and send the whole thing in one dabba. If you have to be serious about bladder tumor resections in multiple areas, you have to label each specimen as it comes. You have to say, I'm taking from the right side, left side, all this, and label each bottle as it comes and wash it out. Don't keep everything together because you won't know where it is. So go step by step, resect that area first, then go for the orifice. So each specimen is separate so that you know that you've cleared everything. It's very important to do this when you're doing bladder tumor resections. All right.
Yes, sir.
Yeah.
So we'll close for today, but Praveen, there's a homework for you.
Yes, sir.
Please find out what is opportunistic screening. Please find out which study has been done on opportunistic screening and tell us what it has said about the use of opportunistic screening. Is it better than population screening or worse?
Okay, sir.
With what reference to?
Karthikeya and this patient had a PSA.
Oh, right. Okay. You're talking of opportunistic screening in terms with reference to prostate.
Yes.
So the first part of the discussion
Right. Okay. Sorry.
went into the prostate because the PSA was done.
Right.
So the new PGs, they can send me the email IDs because I'll be sending the question.
Right.
So I think some PGs have joined in Puttaparthi also. So
Yes, they have.
they can send it here.
So if this patient has been operated, Dr. Pranali, then we can discuss this next week, further management.
Okay, sir.
Any further procedures been done?
Yes, sir. Scopy, ureteroscopy was done, sir.
Okay, if you have images or if you have the histopathology, maybe you can bring them up and next week we can discuss this.
Okay, discuss it next week.
Okay, sir.